Один метр.
Алло. Сейчас. Анастасія. Він ніби є, але от не включено. Так? То що, починаємо? Ага. Включено? Dear colleagues, we are very glad to see you today here in this room. And today we continue the series of lectures by Professor Девід Джейн and his colleagues from University of Leeds. And first of all, before we start, I'd like to say that this program, UKUA Visiting Professors, was established by the Fund of Presidents of Ukraine by Education, Science and Sports. And now I would like to welcome the director of the Fund of President of Ukraine in Education, Science and Sports, Yuri Petrushenko, for the welcoming word. Please, can we? Yuri Petrushenko.
Dear Professor,
Yeah.
dear Professor Devin, on behalf of the Fund of Ukraine and Sport, I want to thank you for founding the visit in this difficult time for our country. І також я хочу сказати колегам Буковинського університету вдячність, що проявляєте активність, залишаєте іноземну для того, щоб студенти, які залишаються в Україні, відчували, що кращі міжнародні можливості доступні сьогодні тим студентам, що навчаються в Україні. Наш фонд має на меті зробити все, щоб найкращі і талановиті діти залишалися в Україні. І ті, хто зараз за кордоном поверталися. I'm sorry.
Mr. Yuri, we are very sorry. We had technical problems. We welcome you for the welcoming word. The floor is yours.
Я ще раз хочу подякувати колегам з Буковинського університету. Знайшли можливість запросити професора з Великої Британії. Це дуже важливий час, щоб демонструвати країні, які залишають учасники в Україні, які міжнародні можливості сьогодні відкриті. Також наш фонд хотів би, щоб цей візит професора Девіда Джейна став першим кроком для розвитку не тільки освітньої спільної кооперації між Буковинським та університетом Лідса, а також початку наукової співпраці. Ми продовжимо нашу програму запрошення іноземних професорів і запрошуємо Буковинський державний медичний університет також брати участь в інших програмах. Бажаю вам гарної лекції і щоб вона стала незабутньою, корисною для студентів і викладачів.
Thank you very much. Thank you very much, Mr. Ray. And the next, I would like to welcome Rector of Bukovina State Medical University, Professor Igor Gerush. Professor Gerush, floor is yours.
Good afternoon, everyone. Dear Professor Jane, dear Dr. Coughlin, I'm very happy that you are here. We are welcome you to Bukovina State Medical University. First of all, I want to tell you that it's a great opportunity for our students, for our teaching staff, for all of us to meet our friends from Leeds University, because we have a very long period cooperation to our university, between Bukovina State University, Medical University, and Leeds universities. It's a great honor for me that first I met David Jane in 2024 in Leeds, and after that it's a start of our cooperation between our university. And I met Patrick 2023, yes, first time, when you visited Chernivtsi between Kerevnik Consulting Group and Twins University in UK and Ukraine. I want to tell thank you for President Fond of Education, Science and Sports, because this fund is supported this mobility of a UK professor to Bukovina State Medical University, and I hope that we will have a very long, live, fruitful cooperation between Bukovina State Medical University and Leeds University. David Jane, one of the leading professors in the robotic surgery, in new technologies, and I hope it will be a very start point to cooperation between team of David Jane, Patrick Coughlin, and between our surgical department of our university. I hope that this event will be very interesting for all of us. I hope for next fruitful cooperation between our university, and I want to invite David Jane to your lecture. Thank you that you are here. Thank you for that you brave man who don't afraid to visit Ukraine in this difficult time. I want to say thank you for all support from United Kingdom in this period for which we receive in this difficult time of war. And I hope we will win, and we will meet in peaceful Ukraine, and we will have a very good cooperation together. I invite you, and we are happy that you are together with us.
Yeah, I would like to introduce our guests. Please stand up. Professor Devід Джейн is the chair of surgery of Bowel Cancer UK, Royal College of Surgeons, and University of Leeds, and Patrick Coughlin, who is the director of Vascular Institute, University of Leeds, and they are here today, and they will represent you new material. And Professor Jane, please, the floor is yours.
Okay, thank you. So thank you very much to Rosalind, to Anastasia, to the rector. On behalf of both myself and Mr. Coughlin, we've only been here a short time, but it's been absolutely fantastic. We've had tours of the simulation center, of the hospital. We've seen an awful lot in a very short time, and I think it's given us inspiration for perhaps how our two institutions could work more closely together. So my name is David Jane. I'm Professor of Surgery at the University of Leeds. Where is Leeds, you might say, and that's a reasonable question. So I don't know whether you can see in this the little map of England there. Leeds is in the north of England, so you can draw a line across the north of England from Liverpool, Manchester, Leeds, Hull, and it's on that line. So we're quite different from the south of England. The north of England has a very industrial heritage. So Leeds in particular was quite a heavy industrial town. It was a big milling town because we have countryside around us, so textiles were what we were quite famous for. So the textiles would be made in the warehouses in Leeds, and they'd be shipped out on that ship canal, which went all the way from Leeds to the docks in Liverpool, and then from there around the world. So Leeds is the regional finance and business capital for a county of England that's called West Yorkshire. So just to put that in context, Yorkshire has a population of about 5 million people. So that's the same size as Scotland. So we're that sort of size. So Leeds is the capital of that. We do have some beautiful surrounding countryside around us. It reminded me actually on the bus coming from the airport over here, you have some beautiful green countryside, and actually the similarities to back home were quite striking. We do have some other things. We have a football club that hasn't done very well recently, but is getting better. So we have Leeds United, and we've got big hopes for them going forwards. So we have two main hospitals in Leeds, but they're run under the same umbrella. We have an old hospital, you can see on the right, that's Leeds General Infirmary, and that's where Patrick works. And then we have the newer hospital, that's St James's Hospital, and that's slightly out of the city centre, but that's where all the abdominal and visceral surgery is done, and it's where all the cancer centre is. We're very proud of our surgical heritage. We've had some great surgeons coming through from Leeds. Probably the most notable in my area is a chap called John Gallagher. For those people interested in colorectal surgery, John Gallagher was basically the father of modern colorectal surgery. He wrote probably the most influential textbook of the day. I work half my time in the hospital, I work half my time in the University of Leeds. So the university is one of the biggest in the UK. It's what we call in the Russell group of universities. These were the old red brick universities, of which there are 20 in the UK. So it's in the top 100 worldwide. It was established in 1904, and we have around just over 37,000 students. It's very much a campus university, so in the middle of the picture, all the university occupies that central bit, and then just below there, it is actually very adjacent to the hospital. So the hospital and the university are set up to be a good partnership. So in terms of surgery, I'm just going to give you a sample of some of the things we do. We like to think that we work across the surgical care pathway. So we have research projects in early diagnosis. So how do we diagnose people earlier? How do we get them into hospital? Once we get them into hospital, we're concentrating on moving away from the big traumatic surgeries. How do we make surgeries more personalized, minimally invasive, so we can actually get people home quicker? And then, once we've operated on them, what is it we can do to get people home safely, particularly bearing in mind that our populations are aging, they're increasingly frail. So we want to get people home safely and to rehabilitate at home rather than having them stuck in the hospital environment. So some of the things we're interested in right at the beginning of that pathway, how can we make sure patients are as fit as they can be for surgery? And that's important because you need to stratify care pathways. If someone's unfit, they might go to intensive care or high dependency afterwards. If someone's fit for surgery, then they will go straight through a normal surgical care pathway. And if you get that wrong, then the wrong patients end up in the wrong place and the efficiency of the whole system falls apart. So we're actually quite interested in remote patient monitoring to see if we can stratify our patients for surgery. This is an example of a project we've got ongoing about minimizing the trauma of surgery. So this is for liver cancer and for renal cancer. Previously, we'd have done bigger operations and we'd have taken part of the liver or part of the kidney, if not the whole of the kidney away. And now we have ablative technologies, of which there is a whole range. This particular one that we're interested in uses ultrasound, and it uses ultrasound to cavitate the lesion. It vibrates it and cavitates the whole lesion. And it will destroy a tumor, but it will leave all the vital structures, the biliary system, the blood vessels intact. So this is transforming liver cancer surgery into basically a one-day hospital stay. We've got a very good robotics set up in the University of Leeds, and this is another example. This is robotic colonoscopy. So colonoscopy obviously is part of our bowel cancer screening program, but one of the problems we have is people don't like having a colonoscopy, so the uptake of colonoscopy is low. And the reason for that is because colonoscopy is fairly unpleasant. It can be quite painful. So what this robot does, rather than having a colonoscopy where the scope is pushed around the bowel, this uses a robotic magnet to gently pull the scope around the bowel. So it's a totally different mechanism. It is painless and it's actually very quick. And it's also something that is very mobile. You could put this in the back of a van and take the screening to patients. The last area is immersive technologies. I think the things we're going to be able to do with immersive and mixed reality technologies, they're going to be increasingly deployed in the future. Our interests tend to be around neurosurgery. So if you've got a complex brain tumor, how do you explain to a patient, we need to take this out, but we've got to be very careful, because if we stray too much here, you might not be able to speak, you might not be able to walk, you might lose your vision. So these are very difficult situations, and the more information, particularly this mixed reality, then I think it is going to be a game changer. But what I really want to talk about, or I've been asked to talk about, is something we've been doing a lot of work on, and that's fluorescent-guided surgery. And the first part of my talk, I'll talk about its main application that we use it, and that's something called an anastomotic leak. And then I'll move on to other applications of it afterwards. So fluorescent-guided surgery has really become very, very popular for two reasons. One, we've got a dye that is very, very safe. Indocyanine green. It's CE marked, it's water-soluble. You inject it into the bloodstream and it binds to the plasma proteins. So it binds 90% to plasma proteins. What that means is it stays in the vasculature. So it's very good at showing you, it gives you a perfusion angiogram. It's also cleared very quickly. So it is clearance through the liver in around 5 minutes. Oh. So as I said, anastomotic leak for us as GI and bowel surgeons is one of our biggest problems. You do a cancer operation or any other operation, you take the tumor out, it leaves you with two ends. You join those ends together, it looks perfect. But then 3 to 5 days later, it falls apart. And if it falls apart, it's a disaster. Not just for the patient, but for the healthcare system and for everybody. So how can ICG help us? Well, this is a left-sided bowel resection, so we've mobilized the left side of the bowel. We then inject the ICG, and you can see that this green fluorescence indicates the perfusion. So we know that the perfusion to this bowel is as good as it can get. When we extract the specimen, we can perfuse it, give a second ICG, and we can see that demarcation where the fluorescence stops and there is no fluorescence beyond. So that indicates the level where we need to transect the bowel, and we can be confident that we've got good blood supply at the anastomosis. And then when we do the join, we can look from inside and you can see the anastomosis, the stapled join there, and you can see proximal beyond that is nice and green, it's got a good blood supply, and below it, it's got a good blood supply as well. So fingers crossed, we've done everything we can to ensure that this bowel will heal. But what about this case? We've mobilized up the left colon, we've given the ICG, and there's nothing. We're not getting any fluorescence. We get fluorescence right up the top, but the rest of the bowel has been made ischemic. So that's problematic. And were we to do a join using this bit of bowel, it would fall apart. And what about this? This is another join that we've made. We give the ICG. We can see the proximal bowel comes really green. It's got a brilliant blood supply. But what about the bit below? It looks pink, doesn't it? It looks pink, it looks healthy, it looks normal. But with ICG, we see there is no fluorescence. What do you do about that now? So to try and work out some more information about this, we got some funding from our UK government to do a randomized controlled trial. And what we wanted to do was compare the standard white light laparoscopy with laparoscopy with ICG. So a very straightforward, simple study design. We had to do it across Europe because of the number of patients we needed. We needed 880 patients with rectal cancer. So it was a true European collaboration. And what we were interested in was obviously if we give the ICG and we get the good healing, does it result in a lower leak rate, this clinical leak rate at 90 days? And we classify leaks into A, B, and C's. C's being the worst, they're big leaks. B's being middle, they're middling leaks, and A's being small leaks that you don't usually have to do too much about. So we're interested in the clinical leaks, that's the B's and the C's, but also all of them, the A, B's and C's. And what we showed was with ICG, when you didn't give the ICG, the leak rate was 15.2%. So 1 in 8 patients undergoing rectal cancer surgery had a leak. That's quite a lot, but it's comparable to what the literature tells us. if you gave the ICG, you were able to reduce that down, not to 0, but it took it down to 10%. So we could produce a benefit by ensuring that the blood supply was as good as it could be. And when we looked at all leaks, not just the B's and C's, obviously with all leaks, the number without ICG was higher. 1 in 5 were getting a leak, 20%. And that came down to 13.7% if we used ICG. And the reason for that is that when surgeons were given the ICG and they were looking at the fluorescence and the blood supply, in 12.5% of cases, they changed their decision making. They altered where they were going to divide the bowel based on the ICG. And that compared to only 7% without the ICG. So there's a mechanistic explanation behind this. And as you might expect, if you've got less leaks with ICG, then the overall complication rate was reduced to 38.5% as compared to 45% in the no ICG group. And similarly, if you've got less leaks, you're going to have less re-interventions at 90 days. So ICG is good. We know it can reduce the rate of anastomotic leaks, but it's still a subjective measure. It may be better than white light. It may be better to differentiate a change with ICG, with green fluorescence, than white light, but it's still very subjective. So the challenge now is, how do you take the subjectivity out of it? How do we quantitate the fluorescence? So rather than just saying it looks okay, we can actually put a number that says this number tells us that it is safe to join the bowel. And this is just demonstrated by a colleague of mine who did this study, and it looked at novices in blue and experts in using ICG, and you can see that there is huge variability. These error bars are massive between different people and how they were assessing the fluorescence. But what you can see is the error bars in the blue are much wider than the error bars in the red, the experts. So although there was variation between experts, there is a learning curve to using this technique. So a lot of time and effort has now gone in to trying to quantitate ICG fluorescence. And there are several ways of doing this. The bottom graph shows a typical fluorescence timeline. So it's flat at baseline. When you give the ICG, there's a steep slope up. It then plateaus, and then it slowly decays again as the fluorescent dye is washed out. And you can measure various aspects of that fluorescent timeline. You can measure the height of the fluorescence, so-called Fmax. You can measure the time to go from baseline to maximum fluorescence, that's called the Tmax. There's various different things. So this study looked at 112 patients. It's from Japan. The leak rate was 4.5%. And what they found, it was the Fmax, this maximum fluorescence intensity, that they believed was to be the best indicator of anastomotic leak. But there's been several studies in this area. So this is another study from Japan, the same fluorescent timeline curve. But they found that the parameter of interest was something called the time ratio. And that ratio is the time to half maximum fluorescence over the time to maximum fluorescence. So it just gives you an indicator of the steepness of the curve. And they found that if you use this, if you had a ratio of over 0.6, so that's the red dots over the horizontal line, those are the patients who leaked, and they mainly fell into that category of having a time ratio of greater than 0.6. there's a big debate in colorectal surgery about where you should divide the blood vessels to the left colon. Some surgeons will say you must divide them as high as possible because then it ensures that you get the maximum number of lymph nodes. We know that the lymph nodes follow the blood supply, so if you take the vessel very high, you will get all the lymph nodes. But there's a trade-off with that, because if you divide it very high, you're also compromising the blood supply to the bowel, mainly because a high tie will take another branch, the left colic vessel, with it. And what this study demonstrated quite nicely is if you look at the graph, the red and the blue lines, that typical fluorescent timeline, and this is with a low tie. So the low tie has no real effect. There's no real difference between the blue and the red. Whereas with the high tie, which is the green line compared to the purple line, you can see if you do a high tie, it will compromise the blood supply to the left colon. And these are perhaps demonstrates that we need to give a lot more consideration, particularly in elderly patients who quite often have vascular calcified vessels, as to how we deal with their bowel resections. So I just want to move on to some other applications of ICG. It's very good for defining normal anatomy. So on the right, you can see that this is defining the vascular pedicle in a nephrectomy. So you have the perinephric fat, which covers everything. It might not be particularly easy to see, but once you get the ICG, because the ICG stays in the vessel, then it becomes very obvious. Similarly, with left-sided resections, bowel resections, you have to avoid injury to the left ureter, because the left ureter is very close to the plane you're dissecting in. And using ICG, you can see that the ureter becomes very obvious. We've also used it in several other applications. So when we have to do a colostomy, quite often when you pull a colostomy up, the colostomy itself can go black, and then you have to take the patient back to theatre to revise the stoma. So it's a very nice technique to make sure that your colostomy is well perfused. In the other case, on the right-hand side, this was an emergency admission, a lady unwell, high lactate, abdominal pain, ischemic bowel on the CT scan. And if we give ICG, we can actually see that the area of ischemic was actually quite limited to patches. This was obviously a microembolic phenomenon. It hasn't wiped out the whole of that segment of the bowel. It was just small areas. So we were able to do quite a limited bowel resection rather than perhaps a whole segmental resection. One of the operations that we do in colorectal surgery is for ulcerative colitis. So ulcerative colitis is an inflammatory condition of the large bowel of the colon. So if you take the colon and rectum out, you will cure the disease. But if you take the colon and rectum out, if you want to avoid having a stoma, then we have to do a pouch. So we take the small bowel, we make a pouch out of it, and we put that down into the pelvis and join it to the anus. And one of the big problems is getting length on that small bowel to get it all the way down into the pelvis. And this is a great technique for making sure that you're not putting ischemic bowel down into the pelvis when the patient is going to get quite poorly. Some of my colleagues use this for biliary surgery. To be honest with you, we haven't had that much success with it. This example is a nice, elective cholecystectomy. It's not inflamed. The anatomy is very straightforward. But it works on the basis that ICG is excreted by the liver. So it's excreted by the liver into the biliary system and stored in the gallbladder. And that's why if you give the ICG 4 hours before you do the operation, it will be in the biliary tree. And the thought is, by using this intraoperatively, potentially we might be able to avoid some of those bile duct injuries that occur. Essentially what ICG is measuring is perfusion, and there's interest in looking at wound healing, because around the edge of a wound you will get angiogenesis, new blood supply and new blood vessels. And there's been some nice studies looking at fluorescence around the periphery of a wound. And you can even use it serially. So you can follow these and map whether the wounds are actually healing as expected or not. So the second part of my talk, what I want to talk about is the use of fluorescence in cancer surgery. And that's two components really. One is using it for better localization of the tumor, and the second is in the radicality of the cancer surgery that we performed. Now, I'm going to talk about this from the perspective of a colorectal surgeon, but these are general oncological principles that will apply to most solid cancers. So we know that lymphatic spread of cancers is the commonest form of cancer spread, and it will follow the pattern of the vasculature to the lymph nodes. Now, we know that only 30% of our patients with colorectal cancer have lymph node positive disease, but we do the same operation on them. If you have a right colon cancer, you'll get a right hemicolectomy. If you have a left colon cancer, you get a left hemicolectomy. And you only need that total colectomy. The point of that total colectomy is to take all the lymph nodes. But that means that 70% of patients are getting a big operation when they haven't even got lymph nodes in the first place. All they needed was a little wedge to take the cancer out. They would still have the same survival. So what we're doing is we're not really thinking about the prognosis of these tumors and what radicality of surgery that they need. And there's a lot of information and variability, and we know about this. There's been extensive pathology studies looking at the lymph nodes from tumors in the colon, and it varies depending where the site of the tumor is. So if you have a tumor in the transverse colon, the pattern of lymph node involvement is going to be very different from if you have a tumor in the cecum. But the important point is that in between 6 and 11% of cases, those central nodes are going to be involved, and they're going to need to be removed. So one of the ways of trying to determine the pattern of lymphatic spread has been to use sentinel lymph node mapping. So what you use is India ink, and you usually inject it at the site of the tumor, and then it spreads along the lymphatics, and the lymphatics show up as, and the lymph nodes as black India ink nodules. And then when you can see where the nodules are, you can determine your resection from that. It has reasonable results in breast cancer. Unfortunately, in bowel cancer, the results have been less good because of the variability in the lymphatic drainage of the colon. So you can use ICG for exactly the same thing. I apologize for the quality of this video. This is a rectum looking down into the pelvis. The tumor endoscopically has been injected with indocyanine green, and then a few hours later it will track up so that at the time of surgery you can actually see the lymph nodes are involved. So you know that in this case these are sidewall pelvic sidewall nodes, so you can resect those on the basis that they might well contain metastatic disease. In head and neck cancer surgery is another example. Obviously, if you've got a tumor in the head and neck, these are very complex areas to get to. There are vital structures around it. It's defiguring and deforming surgery. So what you need to do is to be sure you've removed the whole of the tumor, but not excessive. You don't want to remove excessive amounts of normal tissue. So this is an example of its use in breast cancer surgery. Breast cancer surgery in the UK has a high positive margin, so you think you've got it out, but in 20% of cases that margin will be positive. So in this case, little samples have been taken around the margin, and you can see two of them shine and potentially indicate an involved margin. But what we really need are the images I've shown you so far have been based on ICG, which is a good fluorescent agent, but it's not tumor specific. It doesn't specifically bind to or be taken up by a cancer, and that's what we really need. And so we were interested a few years ago in developing cancer-specific probes. And our attention turned to this molecule. It's called 5-aminolevulinic acid, 5-ALA. And it is actually already used in neurosurgery. It's used for the resection of glioblastoma. And you can see in the images there, you can see a white light image without the ALA, and then you give the ALA, and you have to use it not under near-infrared light, under blue light, and under blue light, the glioblastoma has this actually quite a nice pink colour to it. And then you can base your resection on taking out all the pink and leaving as much as blue behind. And how ALA works is because it's taken up into the mitochondria and is part of the heme pathway. So it's converted into something called protoporphyrin 9, and that ordinarily would be converted to heme. But in cancer cells, there's a reduction in that enzyme, that ferrochelatase. That is lost in quite a lot of cancers. And as it's lost, you get a buildup of protoporphyrin 9, and that buildup, protoporphyrin 9, is a fluorescent drug. And that's why it has a cancer specificity. So we ran a small clinical trial on this, and you can see in this video, this is a patient with cecal cancer. We turn on the blue light, and you can see the cecal cancer fluorescing in pink. And when we look around, this is with white light, we turn the blue light on, and there's pink here in the omentum. So there is an omental deposit here, and we'd have never seen that under white light, so potentially a source of local recurrence. And again, when we're doing our medial resection, you can see that little lymph node shining red just in the fatty tissue. That's a lymph node right at the origin of the ileocolic vessels. So we know that we're taking all those lymph nodes out. So we did a study, a small study. It was a sort of first look feasibility study. Unfortunately, ALA had poor sensitivity. It just didn't pick up. It picked up a few of the cancers, but it missed an awful lot. When it did pick up shine, it was very specific. So if it was positive, it would turn out to be a cancer. So we had a problem with high specificity but very low sensitivity, and we had to leave that alone. So we turned our attention to another dye. This one's called EMI 137, and it targets the c-Met receptor. So c-Met receptor is upregulated on colorectal cancer, so that's how it potentially will give us a differential over cancer to benign. And when this fluorescent molecule binds to the c-Met receptor, it either stays on the surface or it internalizes. It becomes cytoplasmic. And there was some proof of concept. It had been used in colonoscopy for polyp detection. So we thought, you know, if it's detecting polyps, then maybe it's something we can use to help us to detect cancers and lymph nodes. But we had the opposite trouble to the 5-ALA. We gave this to our patients. The problem was that the background fluorescence, the background uptake of the EMI was too much. So the specificity was very low. And again, nice idea, but we failed to show an actual clinical benefit. So having tried and looked for a number of commercially available agents, we got fed up and we thought, well, we'll make our own. So we decided to make a silica nanoparticle. And we chose silica because silica is inert. It's already in use in medical practice. So from a regulatory point of view, it'd be fine. So we made this silica particle, and the advantage with nanoparticles is you can fill them with something. You can put a payload inside, and it can be transported somewhere, and then the payload released. And what we thought is, if we're going to use this nanoparticle to make tumors glow, why don't we put something inside it that actually kills the tumor at the same time? So it makes it glow, and then it kills it. So this is the basis of photodynamic PDT, photodynamic therapy. So to do that, we filled the inside of these nanoparticles with a photosensitizer, and in this case it was a drug called Foscan. Foscan is a commercially available drug. So we put that inside the nanoparticle, and then to make it stick to tumor cells, we put an anti-CEA tag on it. So it's got an antibody-like anti-CEA tag, and that would direct it to the cancer cells which overexpress CEA. Now we were going to do experiments with this, so we needed a control, and for the control, that tagging agent, instead of being anti-CEA, we put an irrelevant target on it, and we put myoglobin. So it had an anti-myoglobin antibody on it. And when we tested it against a number of cell lines, we could see that the fluorescence of our CEA nanoparticle, that's the bars in black, was quite high as compared to our irrelevant nanoparticle, which are the gray ones. So we knew that this was working as it should. It was targeting, and it was relatively specific. So the next move was to look at it in an animal model. So we developed an animal model. It was a xenograph. So these are immunocompromised mice, and they have tumor cells injected into their flank, and you leave it for about a week, and the tumor cells develop into a tumor on the flank. And then we would inject the nanoparticle, and it's done by a tail vein injection, so it goes all over the body, and obviously we were hoping that it would accumulate in the site of the tumor. So we did a number of experiments. When we gave the nanoparticle to the mice and we looked at the fluorescence, we could see in B here that the fluorescence was all in the xenograph. It was all in the tumor. It didn't really go to the liver, the spleen, kidney, heart, etc. And that meant that that anti-CEA antibody was working well. It was targeting, as compared to the irrelevant one, the myoglobin one. Mm-hmm. And that's just illustrated in a different way in the graph in C. In D, what we then did was turn the light on. So if you look at the black line in the bottom left, the black line is our myoglobin nanoparticle. And you can see that the tumor continued growing, irrespective of being injected or having light shone. Whereas the red line That's got our active nanoparticle, and we've shone the light at it to activate it. And you can see that the tumor gets smaller and smaller and smaller. And when we take these tumors out and have a look at them under the microscope, we can see, if you look at under tumor, you can see that when you've had the active particle and the light, then the tumor is necrotic. And that compares with the green image underneath, that's our control. So we've got histological proof that this nanoparticle is actually killing tumor cells. So for the last bit of my talk, I want to just spend a few minutes talking about the concept of living with cancer. So far I've talked about trying to do things to make cancer surgery better, to cure more of our patients. But I think we have to accept that there are some patients with colorectal cancer who you just cannot cure. And the main population of patients are those who have this condition. It's called peritoneal carcinomatosis. So that's when the tumor doesn't spread to lymph nodes, doesn't spread via the blood system to the heart and lungs. It just disseminates around the abdomen. And you end up with this horrible condition here shown in this picture. This is a laparoscopy, a look inside the abdomen, and you see all these white nodules scattered. That's all cancer scattered around the abdomen. Now, you obviously can't, this is incurable. You're never going to cut all this out. And chemotherapy doesn't work for it. Radiotherapy, there is no place for. So we were desperately keen about what else could we perhaps do to try and prolong the lives, not cure, but prolong the lives of patients with this disease. And the thinking was, perhaps we could do what we'd learned with photodynamic therapy, this light therapy, where we give a drug, switch the light on, it kills tumor. When it kills the tumor, we turn the light off. We wait for it to regrow, we turn the light on again. And we can measure tumor growth by the CEA, by tumor levels in the bloodstream. So we could potentially have a therapy we could turn on when we needed it and turn off when we didn't need it. So to look at this, we obviously needed an animal model. So we developed a mouse model of peritoneal carcinomatosis. This is the picture in A here. It's got the mesentery of the bowel, and you can see it's studded with all these white nodules, a bit like what we saw in the patient photo. And these nodules are the metastatic tumor. This time we changed our photosensitizer to something called hypericin. Hypericin is very safe, it's very cheap, it's a well-used photosensitizer. And this shows its excitation and fluorescence. It's got 2 excitation peaks. The advantage of that is we could potentially use 2 different color lasers to try and activate it. And we were able to show on cell lines in the laboratory first that hypericin was very active in our system in terms of killing tumor cells as compared to our true two controls. So the next thing was to develop the light source, because the light, obviously, if you're going to switch it on and off, it had to be inside the body. So could we plant a light source, an LED, inside the body that we turn on, give the drug, and it would do the tumor killing, and then we could turn it off again. So we worked with with engineers. This was actually a collaboration with the University of Texas, who were a fantastic at engineering these micro LED systems. And they made us some little microscopic LED systems that also had a radio frequency tag. You could turn them on and off using radio frequency. And so we were then able to implant these within our model. Oops, can we go forward? Something's happened. Oh dear. This is my best video yet. Is it going to go forward or? Sorry? Yeah. Okay, not to worry. So I was coming to an end anyway. So what I was going to show you is we got this little setup here, and it's a little video of these mice running around, very happy, and then we turn the light on, and it starts shrinking the tumor, and we can turn the light on and off. Don't worry. Well, I've come to the end now, Ruslan, anyway. So I will just summarize by saying that I think fluorescence surgery offers us, opens up all sorts of different avenues for us to explore. It's only been possible because we now do so much laparoscopically using white light. If you're using white light and laparoscopy, why confine yourself just to white light? There are so many different spectrums and things that we can be using. What we've done to date has mainly been based on ICG, and it's good, but it's not specific for the task. But there is a huge number of potential clinical applications that we can explore and where it can be utilized. I think going forwards, there's two things that we need to do, and that's one is to be able to quantify the fluorescence, to take the subjectivity out of it, and there's a lot of work going on there. And secondly, we need better probes. We need tumor-specific probes, particularly on oncology. And there are one or two of those coming through, but we need to see those coming through more, and that will take things to the next level. So I will leave it there, Ruslan, if that's okay. And thank you again for your attention and listening.
Dear Professor Jane, thank you very much, and thank you very much for this lecture, which I hope will be interesting to our colleagues. And for the course of the lecture you've given in our universities, and we also thank your colleagues that supported you with this course, and University of Leeds for our collaboration. And please, dear colleagues, maybe somebody has questions, so raise your hand and please introduce yourself.
First of all, I'd like to appreciate your brilliant lecture. I'm Ruslan. Don't consider that everyone in this hall is Ruslan, just because with Ruslan we share one office. I'm Ruslan Sidorchuk, professor for the General Surgery Department. I would like to ask you to give some comments. It's more on diagnostic side. Can you compare narrowband imaging, confocal microscopy, and standard colonoscopy or other types of endoscopic investigation? Do you have any experience?
I have limited experience. Mainly in the UK, surgeons don't tend to do colonoscopy anymore. They used to, but now colonoscopy has very much become the realm of the gastroenterologist. And it's mainly, I think, it's driven by all the resections. And they are so good at doing the EMRs and the submucosal dissections. Those sorts of things you have to be doing all the time, not a colorectal surgeon who does one a month, you know. And so it's driven it into the hands of the gastroenterologist. So I have little experience of narrowband imaging or all the other things, but I mean, it is revolutionizing the endoscopic treatment of and diagnostics of things.
Yep. Thank you very much. Just to clarify, so most of the polypectomies and primary diagnosis of rectal cancer or colorectal cancer is performed by gastroenterologists? Yeah,
most of our pathways. So if we have a 2-week wait pathway, so if you go to your GP or with symptoms, or you're picked up on the bowel cancer screening program, you go on a 2-week wait pathway. And that pathway is either straight to test, which is straight to a colonoscopy, or into a clinic and then. But we have to have done the investigation within 2 weeks of being referred it. And the people who do all those tests are the gastroenterologists, yeah.
Yep, thank you very much.
Thank you very much. Please.
Okay, thank you for that presentation. I'm Professor Valery Zaitsev. I'm a urologist. But we also deal with ACG for oncological reasons like prostate cancer. And one more thing which we also do is when we shoot localized ureters. I think sometimes in your field it's also sometimes a problem. Not to dissect. And so we use ICG also for that reason. It's very nice. You can see where the ureters are really. And but my question, you have very big experience with this type of investigation. And did you have any side effects or maybe some problems with ICG because of some toxicity or allergic reaction or something like that?
No, we haven't had any. I mean, there are allergies. ICG, as you know, it contains iodine. So if you have an allergy to iodine, that is a contraindication to using it. But having said that, we haven't seen any. The problem, I'm told, is when you mix the ICG up, you need to mix it with water. If you mix it with water, it dissolves completely. If you mix it with sodium chloride, it can precipitate as little crystals. And it's those crystals which can cause the problem with the hypersensitivity and allergy. So no, we found it very safe.
Okay. Are there any contraindication because of hepatic impairment or kidney impairment?
Yeah, mainly kidney. So one of the best indications in the acute setting, I think, is for black bowel. They're telling you exactly how much you can resect, and because it's very judgmental if you don't have it. The problem is most people with black bowel have deranged kidney function, so there's very few you can actually use it with.
Okay, thanks a lot.
Yeah.
Thank you very much. Other questions? Oh, yes, please.
I'm sorry to be annoying.
This is like an exam.
I'm even boring, by the way, with Professor Zaitsev. We're from one department, from the same department. Probably we're a little bit perversive. But the problem is that it's one of the few options to have this live conversation with a prominent guy from the UK. And probably this question is not closely related to the topic of today's conversation. I'd like to probably ask you about the artificial intelligence in surgery. Do you have any experience, your ideas? Because we have a lot of discussions, and most of the opinions, they are very contradictory.
Yeah, so my experience, and we're only just beginning to work with it. I think it's here to stay. It's going to be, and it's like all these technology. You have to embrace it and work with it. If you try and fight it, you know. So the studies we've done, we had a PhD student who used AI to try and predict lymph node positivity in rectal cancer. So one of the biggest problems in rectal cancer, our radiologists will look at CTs and MRI, and you see a node, and they judge it on how big it is, regular contours, etc., to try and say it's metastatic or not. But the accuracy, even with MR, is 50%. Anything with an accuracy of 50% is the same as tossing a coin. It's really quite poor. But what those lymph nodes, what those CT images contain, is so much more information than just looking at a naked eye. And that's where the machine learning, it can extract all that extra information. And we've come up with an algorithm that you can use a CT of a rectum, and we've compared it with radiologists, and it's actually better than our radiologist does. And this is comparing it to the ground truth, which is the pathology. So we've got the pathology, the pre-op scans. We ask the AI, is this positive or negative, it says, and we ask our radiologist, and it outperforms them, you know. So it is here to stay, and there's lots and lots of different applications. Yeah, we have to embrace it and make it do the things that we want it to do for us, to help us, I think. Yeah.
Thank you very much. Again, I'm sorry for being
pleasure.
this sort of boring guy. You remind me about the sentinel node biopsies. What's your attitude towards them? Because again, we once had good experience with sentinel nodes, then the accuracy becomes less, so it's pathology dependent and like that.
No, I think it was an early exploration of the whole area. We tried it a few times. We didn't have much success with it. If you inject it into the wrong place, it just goes everywhere, and it's a nightmare. So I think it belongs in the history books. This is an evolving thing. It's not something we would do currently.
Thank you very much. Please.
Hello, I'm Dr. Shkvarkovsky. Thank you for the very interesting lecture. I want to ask you how you think to enable the something confirmation process in the abdominal cavity due to necrosis of the cancer or something another destroyed process to lead the destroyed result of investigation with your contrast or not?
So this is
make it false. This is result.
Well, so almost using it as a negative imaging agent. So if something is necrotic, you give it, and you get a negative image almost because it's not taking up the dye. Is that what you mean? Or no? Have I misheard that? I think you could do, but I guess it's similar to the ischemic bowel scenario. If it's ischemic, it won't take up the dye, so you get a negative result, and you're basing what you do on a negative result, which will, might be similar. I don't know whether you could use it as a diagnostic. We know that, for example, hypoxic tumors respond less well to chemotherapy, radiotherapy, etc. And that's why smaller tumors tend to respond better to chemo and radiotherapy, because they've got oxygen, they're hypoxygenated. So, but I don't know that this has ever been used to try and predict that side of things. I don't know.
Thank you. Tell me, please, do you everywhere perform D3 dissection if we talk about
And you should probably have, it's reasonable to do a good D2 dissection. But ultimately, you have to tailor it for your patient. If I have a lady who's 80, all I want to do is get her out of hospital alive. You know, D2, D3 means nothing. I know that she's going to die of a heart attack or a stroke in the next 2 years. She's not going to die of cancer from my operation. So what I've got to do is just get rid of that cancer, get her home, some quality of life, before she's going to die from natural causes anyway.
Thank you very much. And we got next question.
Hello, my name is Alina Hernandez Acosta. I'm dental faculty student and I have a question. Which age category, I mean kids, young, elder people, suffers the most from this state, I mean colorectal cancer? Which age category is the most affected of this disease and who has the most risk?
Okay, so that's an interesting question, particularly at the moment. So in the past, colorectal cancer was looked at as a disease of the elderly. And when you said elderly, it was, 70 onwards, yeah? So if you looked at the incidence, the people was from 65, 70 onwards, yeah? And we've seen a very different, over the last 10 years, we've now seen a peak in the younger. And it's a big peak. It's not trivial, it's a real change. And so there's this peak in almost late 20s to 40s. So we've now gone to a bimodal. You see your first peak, late 20s to 40s, and then the second peak from 65 onwards. And it's that early peak that we're most concerned about. Why has it gone up so much? Nobody really knows. Everyone can guess. Nobody really knows. The problem is, when you're young, you ignore symptoms. And you present very late. So they don't come to their GP. If you're young, you get a bit of rectal bleeding, you assume it's hemorrhoids, your GP assumes it's hemorrhoids, you're too young to get cancer. So they're diagnosed very late. The other thing is cancers, as a general rule, if you have cancer as a young person, doesn't matter whether that's breast, prostate, whatever, you will do worse. They tend to be more aggressive. You can think of a young man with prostate cancer, it's a bad disease. Whereas if you think elderly males with cancer, 10% of males elderly will have it and they won't even know. These tumours behave very differently depending on your age and your hormonal status, etc. So we're really concerned at the moment about the explosion that we're seeing in the younger generation.
Thank you very much. And
I have one more question, sorry, like continuation of that one. I mean, all of us who deals with oncology, we saw this shift of the age shift of the oncological disease, and especially maybe for colorectal cancer and cancer. What do you think about possible influence of other processed food? I mean, like grapes, like energetics, like soda, sweeteners, and so on. Maybe nowadays we have very high impact of this food on the health in general, but maybe they could be one of the reasons of these colorectal problems and cancer for young men and women. What do you think?
Yeah, no, I think it's going to be something environmental, yeah? It's something environmental that is coming into contact with your gut, and this predisposition, it's actually setting up the oncogenic process. So I'm sure all these processed foods has something to do with it. I'm also sure that it's probably related to the microbiome. There's growing evidence that the microbiome is involved in, because the microbiome are the ones that produces the toxins, they're very inflammatory and cytotoxic. But it may be that if you're eating different things, then different species are going to develop in your bowel. So I think they are all probably related, but it's quite a complex area to try and tease out, isn't it?
But I mean, do you have any studies about that?
I know quite a few studies around the microbiome and which species were implicated in it. Less so about the dietary side of things, I'm afraid.
Thank you. Thank you very much.
I would like to thank you, first of all, for your lecture. Sadiq Orian, Department of Oncology. I have a question specifically on the cancer-specific probes that you mentioned in the lecture. In your presentation, you said that it can be used for margin detection of the head and neck tumors. What is your opinion of using them for early detection and screening of the oral cancer? Because we can apply and see without any surgery. Is the specificity and sensitivity enough to use it for the oral cancer screening or early detection or not?
So, for which cancer were you?
Oral cancer, oral cavity.
Oral cavity?
Yeah.
I have very little experience of using it in oral cavity. I honestly couldn't answer a question about specificity or sensitivity because I don't have the experience. If I had to guess, I think that the non-tumor specifics are not going to be good enough. It really does need a tumor-specific probe. And I guess for oral cancer, I think we're lucky with bowel cancer because it's one of the few cancers where we have CD8, which is such a good marker. You know, 90% of colorectal cancers will have it. But I doubt that all cancers will have that one biomarker. So it will have to be kind of a panel, I would think. You probably know more than I do what that panel of markers might be. Yeah.
So those probes are more specific to the cancer of the intestine and of the bowel. It's not related to small cell carcinoma in general.
The probes I was talking about are specific to the bowel.
Okay.
Yeah, and yeah, they wouldn't necessarily apply to oral. No.
Okay, thank you.
Thank you, and we have one more question.
Firstly, thank you for your research. I really love it. And I really believe that if we have one research, we find the several ideas to do. In our previous classes in oncology, we studied about the combination therapy. And today I heard that about the fluorescence. And do you ever, in your experience, that you do with the fluorescence with the photodynamic therapy? And does we use the same light for the imagination and for the treatment of that? And what is the really good result with that the combination and the single therapy with the fluorescence?
Okay, can you just, before I get can you just clarify me what, so what do you mean by combination therapy?
Combination, like the combining the fluorescent therapy with the photodynamic therapy, with another dynamic therapy. The two therapies together.
And so the standard chemotherapy alongside it?
Yes.
Yeah, okay. So we don't have any experience of the combined therapy. You know, it is in the literature. There are synergistic effects, and nobody quite knows how they work, but it might work through immune activation. So the photodynamic therapy may have a secondary immune activation side of things, which then complements what the chemotherapy does. That's all in the world of the laboratory at the moment. The main use of photodynamic therapy is in surface malignancies. So if you're going to activate a drug with light, the light has to penetrate. And with, you know, the near-infrared lasers, they can probably penetrate up to probably 8 millimeters, top 7 or 8 millimeters. So it's used on skin cancers. It's great. And the thing about PDT is, again, it will kill the cancer, but it will leave the stroma unattached, because the stroma won't take the drug up into it. So if you use it for skin complaints, cosmetically is fantastic. It doesn't leave you disfigured or scarred. So there's use of it in skin malignancies. But why we were interested in peritoneal carcinomatosis was essentially it's a surface malignancy inside the abdomen, because these nodules grow to about a centimetre. No, they don't really invade in. It's a surface malignancy of the inner lining of the abdominal wall. And I think you asked about the light. It's the same light that excites fluorescence. And then part of the decay is, depending on the agent you're using, part of the decay will activate reactive oxygen species, which will then kill any tumor. Yeah.
Thank you very much. And we have one more question.
First of all, good afternoon, sir, and thank you so much for your nice lecture. So I have one question, as you mentioned in the lecture, that for wound healing also we use ICG, that we can know the time, how much it will take to heal, we can know that. So if we are using negative pressure wound therapy with conservative treatment, so we can give it along with ICG, or we have to do it like, separately.
So what you're asking me is, what does the negative pressure do to the perfusion around there? I don't know, that's an interesting question, isn't it? I think it's a nice research topic for you. You have to do with and without to see what happens to the fluorescence. But I guess it doesn't matter, because what you're doing is taking serial measurements, isn't it? So long as you take those measurements under the same condition, then it's relative, isn't it? But it's an interesting question, I don't know.
Thank you.
So I might be able to help a little bit with that.
You managed to get it.
So I'm a vascular surgeon, and if you've got a low limb wound, we would look to try and optimise the perfusion of them as best we can. There is a recent randomised controlled trial undertaken in the UK that showed that negative pressure wound therapy didn't really have any effect on time to healing or wound healing in the low limb. So we've actually stopped using negative pressure devices on our foot wounds now. It doesn't make a difference. And that's in a sort of a very wide group of wounds, but predominantly diabetic foot wounds.
Thank you very much. Okay. Thank you very much for your questions. Thank you very much for the discussion. Thank you, Professor Jane. Thank you. Professor Gelish.
Dear Professor Jane, thank you for very, very interesting lecture. We have very communication, a lot of questions. Thank you for contribution for education of our teachers, our students, and I want to award you certificate of appreciation presented to David Jane, Zoology to the students and staff of Bukovинskii Medical University for his outstanding contribution to the advancement of surgical science and innovation, for promoting cutting-edge projects in fluorescence-guided surgery and colorectal cancer research, for fostering academic excellence and international cooperation, and for inspiring future healthcare professionals to pursue innovation, scientific influence, and excellence in surgical practice. And next, certificate of appreciation for enormous support and contribution to the development of international academic collaboration, for fostering exchange of knowledge and professional experience, for supporting educational initiatives of Bukovинський University, and for inspiring future healthcare professionals, for pursuing excellence, innovation, and learning.
Okay, so I'd like to thank once more to University of Leeds that started collaboration with us including project. It was in 2023. I would like to thank personally from our university to Mr. Patrick Cockney that started this collaboration together with Professor Devід Джейн. I would like to express our gratitude to Professor Devід Джейн who organized this course of lecture for our university, and to the Fund President of Ukraine for Education, Science and Sports that make it possible to provide this course of lecture in our university and to make it possible for our colleagues to come and visit our beautiful city and our university. And I would like to thank everyone who is sitting now in the hall, who came today and was present and took part in the discussion. Thank you very much and have a nice day.